Yes, of course. Well, hi everyone. I'm Ikra Mom. I'm the program coordinator for MapNet and the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box. Now, I just want to review a few housekeeping items before we begin. So participant microphones will be muted at entry. If you have any questions during the event, please use the chat. This session is being recorded and it will be emailed to all participants once available. If you have any questions after this session, please email newengland@mhttcnetwork.org. At the end of the month, we will send you a certificate of completion that you can submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information on CEs after the event. This slide just provides a description for our disclaimers for MHTTC. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and consistent with our actions, policies, and products. And now, with that, it'll be my pleasure to hand it over to Kelsey Johnson for introductions.
Great. Yeah, thank you so much, Ikra. And thanks, everyone. I see people introducing themselves in the chat. I love to see where people are joining us from today. So yeah, I get to introduce Luis today. So Dr. Luis Sandoval is joining us as a researcher and clinician in the Department of Psychiatry at Beth Israel Deaconess Medical Center, and also an instructor in psychiatry at Harvard Medical School. So Dr. Sandoval is a senior psychologist, supervisor, and researcher with an extensive background in mood, cognitive, and psychotic disorders. So specific to what we'll be talking about today, as a part of his research work, Dr. Sandoval trains and supervises clinicians in cognitive remediation treatment for psychosis and ways to improve cognition in medical and psychiatric conditions. So today he'll be talking more about that, really how does cognition show up in psychosis and what are ways that we can support folks who struggle with cognition. So Luis, I will hand it over to you. Thank you so much for joining us today. Feel free to take over.
Yeah, thank you so much, Kelsey. Good morning. I see a lot of people from Massachusetts, Minneapolis, Oregon. That means I feel honored that you guys are, so early attending my talk. Before I start, I wanted to see some faces. So if you can put the video for a little bit, so I can see some of the faces. I might recognize some of you. I might not recognize some of you, but for me, it's important because if I go to another country, another conference, another state, I might say, "Oh, I remember you," and we can engage in a conversation. So before I talk about cognitive remediation, which is truly one of my passions, I want to tell you a little bit of my style. I think if we are in this business, in this field where we need to treat individuals with psychosis or in the spectrum, I think we need to tell the story so we can relate to the story. We need to use evidence. We need to humanize this, because that's what truly makes the difference when we're doing therapy in this population. So that being said, please feel free to interrupt me at any time. We have plenty time to engage in this dialogue, in this journey, and hopefully you will have a good understanding of what is cognitive remediation, where it's coming from, how to apply it, what are the results that you can expect, and also the expectations of using cognitive remediation in this particular population. All right, again, Dr. Sandoval, and feel free to interrupt me at any time. So without further ado, you can turn the cameras off. That's fine. I will have a little bit of a social anxiety because I will be talking to myself. But if in the middle of that you want to say, "Hey, stop there, I don't get it," that's fine. All right. So I wanna tell you what we're gonna do today. I want to talk about cognitive remediation, a contemporary way to treat psychosis. For me, as a clinician, it's very important to know where is this technique is coming from, how it evolved, who invented it, why we created this, and how psychiatry adopted it in this particular population. And then I also want to talk about, I want to bring two cases. All the data is completely unidentifiable. You won't know who it is. I want to tell you something that you probably can relate. And I want to show you two particular techniques, how we did it and what are the results. And at the end, tell you if this intervention is good or not for your setting, whether it's private practice, community health clinic, hospital, research center, etc. All right. So why cognitive remediation in psychosis? I'm not going to talk, a lot about schizophrenia. I'm pretty sure you guys are very familiar with this. If you're in this conversation, that means you're familiar. But I want to tell you the four or the three pillars with a little bit of caveats about schizophrenia. We all know positive symptoms are the most popularized symptoms, like the visual hallucinations, the auditory hallucinations, right? The tactile, the delusional thoughts. We have the negative symptoms, which is mostly about the affect, the motivation, the social withdrawal. And very little clinicians know about what are the cognitive impairments that comes with psychosis or schizophrenia. And we wanted to think about in two particular ways. We want to talk about the neurocognition or the neurocognitive abilities and the social cognition or the social cognitive abilities. That is the key of cognitive remediation. If we talk about the neurocognition, it's basically all the cognitive abilities. We're talking about attention, memory, problem solving, versus social cognition is understanding the emotions, my emotions, the other emotions in the right social context, in the right social interactions. We know that their CBT for psychosis, we have antipsychotic medications, but what do we have to treat neurocognition or the cognitive components of this particular psychiatric illness? We have another problem with this. We live in a society that we tend to medicate everything, and we try to do, we have pharmaceuticals, we have a lot of research going on, we're going after the genes, and that takes a lot of time, and the evidence is going, closer and closer. But until today, we don't have any medication that can help us to improve the neurocognition or the social cognition. I mean, it will be amazing if you take a medication and all of a sudden your memory is back. Or if you take the medication and then you can problem solve between, do I want egg Benedicts or scrambled eggs for breakfast? Or even amazing that if I take a medication, I will understand what is the social context and I will be able to relate with other people. That doesn't exist. However, we know that there's medication, specifically anticholinergic medication, that can affect cognition. You will see these effects in individuals who are medicated with with lithium, that all of a sudden will say, I feel more foggy. Is the bipolar with the psychotic features? Is my delusionals? What's happening here? Well, the medication might be affecting your cognition. So, in other words, we don't have medication to improve cognition, but we do have medication that can decline cognition, right? So what are the cognitive impairments in schizophrenia? Here's a beautiful acronym that one of my mentors, Dr. Kashevan, came across, that if you want to talk about neurocognition, just think about SMART. Speed, memory, attention, reasoning, tact, synthesis. If you remember that acronym, you can start thinking about your clients and say, where is the how smart is Pedro? Is the speed of processing okay? Is the memory okay? Is his attention okay? What about his reasoning? What about his tactful way of understanding things? What about his capacity to understand and synthesize information? The other part, as I said in the neurocognitive components, is the social cognition. What are the mental operations underlying the social interaction of Pedro? What is the ability and capacity to perceive his emotions, my emotions, to regulate his emotions, his intentions, and disposition of others? So, as I said, there's no medication for it. There's nothing available there. We can do some of the traditional psychotherapy. We can do DBT for emotional regulations, for example, but we can do a little bit of AB treatment for socialization, something that is being used in the autism spectrum disorders, but nothing much for schizophrenia. So why we're putting a lot of emphasis on the neurocognitive components here? Because we know that 80 to 90% of the cognitive components are related to the functional impairment. So that means that for every 10 clients with psychosis, we know that at least 8 or 9 of them will have some cognitive decline. It can be in selective attention, it can be in working memory, it can be in problem solving, etc. And what happens if we have such a cognitive decline? Well, the quality of life will decrease, their socialization will decrease, and is going to have an impact in their self-esteem and image, right? It's important to know that if the cognition improves, it's a fantastic predictor for functional outcomes. That means the more that we try to repair or enhance their neuro and the social cognition, the better chances that the individual will be able to go back to the society and integrate and be part of the workforce and keep, having the relationships going, their interactions with their kids, family, peers, etc. It's also very important to know that cognitive declines occur in early illnesses. This is a beautiful article from 2015 that is still very accurate, that if we are in the phase of schizophrenia, we can go from 0.5 to all the way 1.5 standard deviations in cognition. In other words, if you lose 1.1 standard deviations of cognition, that means that your memory, your capacity to process information, your capacity to react to external stimulus, the capacity to engage in a typical conversation is going to be very impaired. So we need to pay a lot of attention how it evolves, and we need to pay a lot of attention when they come to our clinic or practice to see what's the current damage and if we can reverse something, right? So that being said, why we're talking about cognitive remediation is because we have a big problem. 8 or 9 out of 10 will have a cognitive decline, and there are no other treatments to repair that. We're very good at treating depression, we're very good at treating anxiety, we're very good at treating the positive symptoms, sometimes the negative symptoms of the psychosis, but we don't know, and there's not enough clinicians that know how to treat the neurocognitive component. All right? So what is cognitive remediation therapy? Where it started? Well, I'm pretty sure you won't be surprised when I said that the story of the cognitive remediation started after World War I veterans who suffer a severe brain trauma injuries. So as a lot of the history in psychology, a lot of the interventions, developed because of the military, developed to screen soldiers so they can find that they can process information. So in this case, it came after, because there were so many wounded, there was so much brain trauma, so many injuries, that Germany and England, if you know, in the World War I, they were losing a lot of men, but they needed to go back and fight. So for that reason, cognitive remediation was created as a way to try to target the cognition of the soldiers to go back and fight. They defined it as to improve cognitive functioning and adaptive behavior by teaching skills and strategies that can be transferred and applied to real-world situations. So if you have the brain injury and you couldn't follow orders, what they will do is just to rehearse. Soldier, you have to do this, you have to go back, you have to go there, grab the rifle, aim, shoot, practice, right? And back then, they were, that was the beginning of the World War I, ended. We have another war. We have a lot of injury. We have a lot of trauma, a lot of brain injury. And scientists were thinking about how can we repair cognition? What else can we do? And they come up with multiple methods of cognitive remediation. One of them is called the simulation therapy, which is the original one, the oldest of cognitive remediation. Is a direct retraining and is based on the assumption that cognition functions will improve to simulation of the cognitive system. For example, if you don't remember the name of your partner, then we need to retrain and go and memorize and drill and drill and drill until you memorize the name of your partner. Or if you don't remember how to go to your house, then you will rehearse with a clinician going back to the house all the time so they can relearn. The other option was processes of training, which focus on a specific areas of cognition, because not every brain injury is affected equally. Pedro might be affected by, memory, versus Lucille will be affected more of visual scanning or sustained attention. If that's the case, then you will completely focus on attention to Pedro and visual scanning to Lucille. And how you're going to expose it to a lot of visual stimulus and then rehearse and rehearse. Then we have another approach, which is attention and concentration training. As the name says, we're just gonna talk about the ability to focus on attention, maintain vigilance, and restrict distractions. This is very important because when someone has a brain injury, right, their thoughts are all over the place. It's very hard to concentrate, to keep track, to follow one idea. So they will do a lot of redirection, saying, Luis, let's stay focused here. Let's stay focused here. So it's another way of retraining the process. And then it started to evolve. And then we have the strategy training that involves teaching a person mental sets that are applicable in a variety of contexts. For example, a therapist might teach a person with traumatic brain injury to use a certain strategy to problem solve or mnemonics. If you see here in these methods, psychologists are still not part, or even social workers are part of this approach. This approach was usually delivered by OTs, occupational therapists, right? Which are fantastic clinicians to do this kind of interventions. They can do the retraining, they can expose them to cognitive exercises, they can just, reshape things, but psychiatry was still not here, right? Cognitive remediation continue evolving, and they have, other approach, which is, what if this is related to the nutrients and the drug treatments? And basically they said, the one way to understand how to repair cognition is that if Pedro has, drinking a lot, and we know that the effects of alcohol in the brain, if we get him sober, by definition, it will improve cognition, which is a valid argument, right? And this is something that we, as a clinicians, we always need to be aware of it. what are the other drugs or what are the other substances that might be interfering with their cognition. As I mentioned before, one of them might be the anticholinergic medication. So, and then we have a more practical way, which is just try to teach the client to use prosthetics. Well, if someone is having problems taking notes because of their attention, well, just train the person that has poor memory, poor attention to use a tape recorder, you know, or in this case, now with the current technology, make sure that you have your iPhone or your Samsung Galaxy or other device on recording so you can re-listen the tape and, you know, do the cognitive component that you can't at the moment at your own pace because of the devices. The other one is domain-specific training, which is basically emphasizes training a person to function within a simulated life experience. This particular approach of cognitive remediation is role-playing cognitive and social situations. For example, if I'm having troubles with math, simple math, and I have problems with a little bit of anxiety or social anxiety, but I really like coffee, but I'm terrible at math, then one thing to do is to go to the local Starbucks or Dunkin' Donuts or Tim Horton, whatever your local coffee shop is, and say, well, Pedro, do you know that the coffee is around 250 or 275? What if we use always a $5 bill? And then what is the expectation? You're going to pay with this, and then they're going to give you a change, and the change is going to be 175 or 125. And so you're going to rehearse that interaction. So at that point, Pedro can go by himself to the Starbucks, feel confident that we'll get the coffee that he likes, and just double check two things. One, he gets a $5 bill and he gets the same amount of change every time. That helps with a lot of autonomy. That helps to rehearse. That helps with improving cognition. No? And the other one is indirect training. So basically saying, well, I know I'm doing this with Pedro about the coffee. I know I'm going to give him a $5 bill, but what if I also teach him how to sleep better, how to exercise? So by teaching him the sleeping part, I'm going to indirectly enhance the cognition, or at least to less interfere with the cognition. And probably Pedro will be able to manage those tasks better, right? So all these methods are out there. Some of them have more research evidence, some others less, some others are more practical, some others are more complicated, and this basically the history of cognitive remediation. So you can come, you know, a lot of people have asked me, Dr. Sandoval, can you do cognitive remediation with an apple? And I will say yes, yes. Because if you know what you're gonna do with the apple, you can use it in a multiple way. So for example, I can say, all right, Lucille, we want to use this apple to do cognitive remediation. I want you to describe it. I want you to pay attention to it. I want you to process the information. I want you to do many things. So you can use so many tools out there as far as you attach the tool to a particular cognitive domain or a social domain. And I will give, we'll give you more examples as I go further, and I explain how it's done, right? But this is, again, this is just more for the brain injury point of view. This is back in the 50s, in the 60s, in the 80s, right? Early 70s, early. But then, so if we put all these methods together, the definition that they have for cognitive remediation in general is a cognitive rehabilitation in a complex collection of techniques designed to enhance perception, attention, comprehension, learning, remembering, problem solving, reasoning, and so forth. So basically, specific parts of the brain. Okay? But what does that have to do with the schizophrenia? So what is the history behind cognitive remediation in schizophrenia? Well, cognitive remediation started in the 70s, where Benny Shai, I believe was a neurologist and also very attached to the psychiatry department in New York, where he said, well, wait a minute. I know that my clients who have psychosis, that they don't have a brain injury, they didn't have an accident, they didn't go to work, they didn't have, a concussion. I know that they're losing cognition. And how do I know that? Because when I ask them, what do you want to have for breakfast? They spend between 30 seconds all the way to half an hour just to decide if they want cereal or toast. If you cannot decide because your brain is foggy, because you're feeling anxious, because you don't know what's happening, that is a cognitive decline right there, right? So understanding, and back in the 70s, we didn't have the concept that psychosis came with a neurocognitive component or a cognitive decline. So that was very innovative back then. And say, well, what if cognitive remediation? So we want to start seeing the positive, the negative symptoms, but now we want to pay attention to the cognitive components. And this is where Machiavelli and Cameron in 1973 start to improve the attentional control using verbal directives. Back in the 70s, only probably NASA and one of the big companies will have access to computers. So the majority of the cognitive remediation back then was paper and pencil and photos. So they would try to use some verbal directives to say, okay, Ruth, I know you're having problems recognizing or sorting information. What if we focus just on organize these 5 photos alphabetically, for example? No. So in the 70s, the scientists, the psychiatrists, the social workers, psychologists got together and they started to do a lot of clinical trials to see whether the schizophrenia patients will improve their performance on a specific cognitive task. So we know that they have troubles deciding between cereal and toast, but can we pair this with testing, with the golden batteries like the Wisconsin cards, to see if I'm working on this paper and pencil interventions, telling Ruth, can you sort these 5 words alphabetically, are they gonna give us improvement in this standardized test? And the answer was yes, right? So in the contemporary way of doing cognitive remediation, in particular in psychiatry or in mental health, we need to think about what is the neurocognitive approach. And the neurocognitive approach can be divided broadly in 2 categories. We have the bottom-up or the top-down. Perceptual skills of bottom-up is basically basic cognitive processes. If we want to talk about the brain, we're talking about the most primitive part of the brain. And what's the most primitive part of the brain? You need to pay attention. You need to process information quickly. Otherwise, the dinosaur is going to eat you. Otherwise, the tiger is going to catch you, right? So one way to start doing cognitive remediation is by focusing on basic cognition, with the hope that if we repair the basic cognition, it will be easier to go to higher level cognition and executive function. So attention, reaction time, processing speed is basic cognition. Memory, problem solving will be top down, higher level of condition. But we have so we have good and bad things with the bottom up approach. If we do the bottom up approach, definitely enhances early perceptual processing in schizophrenia, as well as improving verbal learning and memory. The problem is that did not translate significantly into the community, or in the research, we call it the generalizing the results. So that's a problem, right? It doesn't matter if we work heavily on reaction time, if we cannot tie the improvements to general concepts or general abilities in the community, we're going to turn someone into responding very fast for a particular stimulus, but nothing else. And that is a problem. If we go to the top down, the top down is designed to train higher level cognitive processes with the aim of transforming gains to the other basic and complex cognitive domains. Top down approach has been very effective at improving problem solving skills. And if you improve the skills, they will persist, they will stay there. Now, what people don't tell you when you read these particular authors, what people don't tell you is that it's very good to do top down if the bottom up part is there. Meaning, if the patient, the client that you're working with has good basic cognition, basic bottom up, the foundations, of course, it's going to be easier to work on the memory and the problem solving. But if someone doesn't have that part, going to memory or problem solving is going to be very, very difficult to do. And you will, and not only you, but also the individual will feel the frustration. So who knew, and I want to talk about this, the next new programs, who knew that if you integrate both things, if you work on the basic cognition and then the bottom up, and then you lay the foundation, and then you work on the top down, who knew that they're going to improve in the neurocognition, social cognition, and quality of life and functional outcomes, right? So there are multiple cognitive remediation, I would say, treatments, modalities, approaches. So the ones that I'm intimately familiar with is the neuropsychological education approach to remediation program, acronym NEAR, or the cognitive enhancement therapy, CET program. One is, teaching in New York, is in the Medallia group, and the other one is CET, which is Hogarty, Dr. Ig, Dr. Kashavan, and myself in the Boston area. So we talk about the neurocognitive approach. How are we gonna start with the bottom up, or we want to start with the top down? But now we need to talk about what is the technique. And the technique is basically divided into drill and practice, which is you have poor attention. We want to focus on attention until you improve, until you see significant change. And then we move to another level, right? So you have to practice. And it's practice the same task, doing simple calculations or memorizing the same photos or memorizing the same list of words, is just drilling. What happens if you're going to take the CRT approach of drilling and practice? As a clinician, you need to be very involved. You have to be an active therapist who facilitates the development of the alternative cognitive strategies. So you're going to say, hey, Ruth, remember, we want to try to memorize these 5 photos. What is it that you're going to do? What is your strategy? And then Ruth will say, what if I create a mnemonic? Said, sure, but if the mnemonic doesn't work, then the clinician will say, hey, Ruth, let's do it again. Seems like the mnemonic is not as strong enough or is not as catchy. Let's change things. Once Ruth is able to memorize the 5 words or the five photos, then we'll say, what if we try 6 and 7? So the therapy is very, very involved, right? So drill and practice. The other technique is strategic thinking. And the strategic thinking is about formulating mental strategies to optimize cognitive performance and task completion. For example, if we use the strategic thinking and we have 5 photos, as a clinician, you will say, all right, what's your strategy? What else can you do? We're going to appeal for a higher level of cognition. Maybe we can do a synthesis. Maybe we can get the gist of the 5 photos. Maybe we can separate into 2 groups or 3 groups of 2, etc., right? So you're going to help the client to build strategies to improve attention, problem solving, memory. If you see with the strategic training, the individual has to have a decent executive functioning, right? What is the role of the therapist? Is to be able to contextualize the purpose of the cognitive exercises, to personalize the learning experience and facilitate the generalization of the learning. So in this case, as I mentioned before, when you're doing just the bottom up and you said you have to react fast. If there is no connection with the real world, it doesn't make sense. The strategic part is very aware of how to use these strategies and apply it to the real world. For example, in a strategic way, if I'm teaching you how to improve reaction time, I will say, what will be a task that you do in your daily life that requires reaction time? And the typical answer is none, right? And they will say, well, no, Ruth, let's talk about something else. What about, do you drive? And it was like, no, I don't drive. Okay. Do you go for a walk? Do you cross the street? It's like, well, yeah. Have you paid attention to the street lights? Well, yes. Well, what happens if you see the red light and your reaction time is so early that you cross the street light when the light is green instead of red? What do you think is going to happen? Oh, I'm going to cause an accident. Sure. So what happens if it's too early? What happens if it's too late? So then, by using a real example, a real life example of crossing the street and doing the reaction time in a strategic way, is very easy to generalize the knowledge here and apply it. Or it's very easy to the knowledge that you're gaining here to apply it in real life. So both techniques can be, the drilling and the strategic can provide a thorough knowledge. Back in the day, we're talking about the 70s, the 80s, even early 2000, we didn't have a lot of computerized interventions. So now we have the technology, especially after COVID. Psychiatry or mental health has been in the front of using interventions digitally. And now we do have the experience that if you have the software to do cognitive remediation, not only it can be evidence-based, it can be brief, it's not invasive, and is very easily delivered in primary care institutions. You just go to the web, use the website, etc., and you can do the interventions. So just to recap about the contemporary techniques in psychiatry using cognitive remediation, you have I want to target bottom-up approach to cognition or top-down. And do I want to use drilling and practice, or do I want to go to the strategic thinking? The answer is that you don't have to reinvent the wheel. The answer is, please combine them, because you need to be very aware of what are the neuro and social cognitive needs of your clients in order to enhance these areas, right? So if you see the definition back then after the World War I and II, is not necessarily the same as the 2010 definition of cognitive remediation. Now, cognitive remediation is defined as a behavioral training-based intervention that aims to improve cognition processes with the goal of durability and generalization. CRT has become a cornerstone of functional recovery. So back then, in the World War I, World War II era, we didn't care a lot about the behavior. But when you go into psychiatry and psychology or mental health, and you have experts in behavior, experts in emotions, we brought that combination of techniques and we're integrated with how to start, how to enhance the brain, repair the brain, etc. Now, here's an interesting definition. A lot of people will use enhancement or repairment, and they will say, "Oh, it's because they're going to improve. They're going to go back to when before the illness or before the accident." Some cases will do, but sometimes repairing or enhancing involves not letting the illness or the neurocognitive decline to decline so fast, right? So you have to be aware of that. That sometimes repairing or working in this area is just to keep maintaining the current level of functioning. And you might say, well, what's the point of just maintaining that? Well, because it's not the same to be able to remember 4 names than only to remember 1 name. And let me give you just a social context here. If your mom had a brain injury, or if your mom developed, psychosis, and she has 3 kids, and she can only remember the name of 1 of the kids, imagine how the other 2 kids will feel. And the answer is awful, right? It's going to create a lot of social tension. It's going to create a lot of, sourness. Not for the person that remembers the name, it will feel the favorite, but for the rest, it can change, right? So remember 3, 4 names instead of 1, it can be a huge, huge change, right? Of course, I'm simplifying this. It's also related to a real story, but you can tell that cognitive remediation can enhance or can help to reduce the velocity of a decline. So that being said, so now we understand why in psychosis, because we don't have anything to repair the neurocognition, the social cognition. What is the history? Now you have all the models. Now you want to see the substances, the prosthetics, the drilling, the bottom up, the top down. So how is it done? Well, I want to talk about the case of Peter. 15. I think we still have time. I want to talk about the case of Peter. I know it's a little bit lengthy, but you can see the flavor that I'm pretty sure you guys are familiar. So Peter is 18 years old. He decided to take, this is before going to college. He decided to take a 7-day road trip with his 5 closest friends. And he reported that one day while he was driving, he felt that something bad was going to happen to them. When his friends asked him why he was worried and looking at the rear view mirror constantly, he said, "The police and the FBI are after us. They want something from us. So if I see the police," Peter said, "I will not stop. Otherwise, we'll go to jail." His friends were confused about what he said, and they laughed at the idea of being chased by the FBI. Peter felt confused at first, but laughed about himself because it sounded like a conspiracy. Well, you're 18, you're with your friends, your first time going for a road trip. It is doable, it's credible, it makes sense. Maybe they were under the influence of drugs and alcohol, etc. Well, then in the first years of college, 2 weeks into the first semester, Peter started feeling lethargic, sad, nostalgic, and had difficulties concentrating. He didn't have enough energy to play music, and he felt nervous and suspicious every time he visited his girlfriend's dorm. When he talked about these thoughts with the girlfriend, she told him that he was probably feeling homesick, and Peter believed that explanation. So very important that we already have some early signs of the cognitive decline, early signs of the positive potential positive symptoms, a little bit of the paranoia, and still with possible explanations saying, Peter, you're just homesick. That happens all the time, right? So after a week after the incident, this particular incident, Peter started feeling more anxious and began to experience suicidal ideation. He left campus and returned home when he was, to see his PCP. He was prescribed with anxiety medication and referred to therapy. He said, no, I think it's anxiety. He believed the idea of the homesick. And he believed that it was common to feel sad and anxious during the first week of college. So they basically normalized the experience, and that everything that he was experiencing was okay. He went back to college and discontinued medication after a week because he was feeling better. Shortly after discontinued medication, he began to paranoia. People were watching him, started seeing lights of different colors and believing that each light represented a particular message. Red indicated do not trust the people. Blue was neutral. Yellow meant they're trying to steal his ideas. He also began to dress differently, including painting his nails and wearing makeup, as he believed that by doing that, he will be able to protect his ideas from other people. He attempted telling his girlfriend about what he was experiencing, but she don't take him seriously because he thought he was using recreational drugs. At the same time, that night, when the girlfriend said, no, I think you're high, you're taking too much of the drugs, Peter went from one bar to another bar until the next morning. He was wandering around the streets when the police found him. To make the story a little bit shorter, when the police asked him what's going on, Peter, he said he was trying to hide from the vampires. He was disoriented, disheveled. The police took him to the emergency room. During the first 24 hours, he was in the ER, developed difficult sleeping, poor appetite, and there was significant decline in the overall cognitive functioning. If we just focus on the red part, 3 weeks after the psychiatric hospitalization, he was found throwing rocks at several windows of a hotel and was arrested for damage to private property. When he asked what he was doing, he said that the hotel had yellow color aura, which meant that there were spies using the hotel as their hideouts. This particular case of Peter is very sad. He couldn't recover from the psychosis. He was diagnosed with psychosis, and at the age of 18, he started his long journey with inpatient psychiatric units. And right now, Peter is in their mid-50s. He lives in a long-term psychiatric facility. So, but he tried cognitive remediation treatment for 2 months, right? And I want to show you a little bit of the software that we use to treat Peter. We use a bottom-up approach. We use the drilling technique, and we use a computerized neurocognitive training using sagacity, and we focus on the reaction time. So I want to stop sharing my screen because I want to go to the other part. Okay, in the meantime, if anyone has a question for me, this is the perfect time. Otherwise, I will continue. Okay. Share the screen again. Can anyone see my screen? I just need one person to say yes.
Yep, looks good. We did get a question in the chat about luminosity. Is that helpful for folks?
I will talk about it. Yeah, good.
Great.
Good. So let me show you this particular thing. This is the software of sagacity. I'm seeing this patient in the inpatient. I'm with a clinician. I have multiple modules. I'm going to use the reaction time. I won't go into deep, just want to show you how it works and why it's important what we did. So basically, this is a way of training and drilling reaction time. So we have multiple settings, 175 milliseconds all the way to 500 milliseconds, which is half a second. We have a target time in seconds, and we have visual and audio aid. The goal of this exercise is simple. We ask them to press the space bar down once they see a green dot lighting up right here where my mouse is. And we have audio and visual aid, and you will see how it works. So again, my job is to react as fast as possible when I see the big green dot on my right. I want to click OK. You see the sound. You see the red. And I want to hit again. So my reaction time in this case is 1,211 milliseconds, which is 1.2 seconds, right? The 4 red circles is related to the visual aid, and the sound is related to the audio aid. Why this is important? Well, if you have been working with the population of schizophrenia and they do have auditory hallucinations, this particular exercise is very important because we are training them to pay attention to the external stimuli. In this case, is the visual and the audio, competing against the internal, which is the auditory hallucinations, right? So we're forcing them to say, Pedro, pay attention to the outside, not to the inside. So they have to work really hard to pay attention to this instead of inside. Now, 1.2 seconds or 1,000 or 1,200 milliseconds is too late, right? So we do it again. And what happens if we do it too early? The software responds and says, well, Pedro, in this case, you are 0.8 or 0.8 seconds early. So that is another way for clinicians to understand if Pedro's reaction time is more into too slow or too early. Too early is usually associated with impulsivity and anxiety, right? Versus the other one might be more about motivation or lethargic. Both ends of the spectrum are related to reaction time. So what if we do it again? And we are in the green score. That means that we're giving Pedro we're training Pedro to react between 0 and 500 milliseconds to pay their attention. Now, I want to tell 2 things about here. One, 105 milliseconds is as fast as a blink of an eye. 500 milliseconds, half a second, is too late to respond to a stimuli. It can change everything. If you're driving, if you're cooking, if you're paying attention to even a conversation. For example, if we cannot, and remember, we're talking about 5 seconds here. If Pedro cannot pay attention for 5 seconds because he's too distracted, what do you think are the odds that as a clinician, when you ask to Pedro, hey, Pedro, do you take your meds? How are you doing today? What are the odds that Pedro will pay attention to what you're saying? And the answer is pretty minimal. So by doing reaction time here, and by doing this particular exercise, not only we're training Pedro to react better, but we're also training Pedro to pay attention in sections of 5 seconds each. So at the end of the exercise, Pedro, whether he's doing too late or too early, we force Pedro to pay attention as much as he can for 1 minute, roughly. 5 seconds multiplied by 10, 50 seconds, plus setting this, minus up is close to 1 minute. So 1 minute, and I will encourage you to do it yourself, paying attention right now for 1 minute, it's a lot. Just go to your phone, watch one of those TikTok videos. If the TikTok video is longer than 1 minute, you're probably going to say skip the other one. So everything has to be super short, right? Now, I want to stop that. I want to share my screen again. So remember, this particular case is a chronic, very ill, a lot of cognitive decline. These are the results from the same exercise with Peter. The first time that we tried it, he basically needed 29 seconds to respond to the green dot. 29 seconds. We tried twice, and then 22, and then his reaction time was longer than 10 seconds. And longer than 10 seconds is basically there is no attention whatsoever. The second time he tried it, and he was almost 4 seconds early. So that means he only saw one red dot and he pressed it. So he couldn't control his attention and the reaction time. And all of a sudden, if you see the green, he will have a decent response or an accurate response. But after that, it was all over the place. And I want you just to look at the red, which is high impairment, extreme impairment, high impairment. So we have blues, a lot of red, and then we start seeing yellows. And yellow is moderate impairment, meaning the reaction time of Peter was between 1 to 1.5 seconds. And by session 7, we're talking about mild impairment and some of them on target. How these translate into neurocognition and social cognition. And these are some of the words that I remember from him saying when we were about session 7. Again, each session is 1 minute. And for the first time, he said, this is the first time in 10 years that I didn't hear my voices for 1 minute. So he was able to encapsulate the auditory hallucinations for 1 minute and just hearing the simple audio from the computer. That changed a lot because in that minute, I can ask him questions and he will be able to respond maybe with 1 second delay, maybe with 2 seconds delay, but that is easy to engage in a conversation versus 29 seconds delay. So this is how important can be focusing on neurocognition, on drilling, and with a coach generalizing some of the experience, even with chronic patients, right? Not listening your auditory hallucinations for 1 minute in 10 years, that was a huge improvement for this particular patient. All right. Now, going back to the Lumosity. Lumosity, I think, is a great software. It's entertaining, it's sophisticated, it's relatively cheap, but I have 2 particular issues as a clinician. One is they don't train the clinician how to use Lumosity as a tool to improve the neurocognition. I think it's a great tool for individuals who are not chronically impaired or are more in the severe spectrum of cognition. I think is a great tool for individuals who are mild impaired or mild some deficits than for more clinical uses. There's a lot of research going on with Lumosity, but I still haven't seen someone with psychosis, with severe decline, improving with Lumosity. And also Lumosity is designed so far as a standing alone intervention. That means it's you against lumosity, you patient against lumosity, and lumosity will give you some feedback, but the feedback is not necessarily clinically tailored. For example, I remember one client coming to me and said, I'm doing lumosity here, I'm doing that. And I said, all right, can you interpret the results? And say, well, sometimes I'm faster than in my reaction time. Well, but sometimes faster is not necessarily a good thing in reaction time. Sometimes faster means impulsive, not necessarily accurate, because reaction time is about speed and accuracy. It's not just pure speed. So what I think is missing for lumosity is just the tailored clinical interpretation that our population needs to have. No? Now I want to talk about another case. We still have time. I want to talk about another case, the case of Brian. Brian is a 30-year-old male who's living, with schizophrenia. He's single, works part-time in a convenience store, and resides in the second floor of his parents' home. Brian had a normal childhood, a lot of friendships, a lot of relationships. During his adolescence, he excelled in academics, in sport, and in social life. And he was the captain of the baseball team in high school and served as the social chair of his prom committee. These skills led Brian to be accepted at the top 10 of universities in the country. So this is a typical story that we'll hear with someone with, ended up with psychosis, schizophrenia, that they were a social butterfly, they were intact, they were fine, but all of a sudden the illness clipped their wings. No? So how the schizophrenia in this case clipped, Brian's wings? Well, in college, he continued to excel during his first years of college. His senior year, his grades began to decline. At the time, Brian stated that he was anxious, overwhelmed, and unable to focus on daily activities. You see, right here, we're talking about now the neurocognition. Brian received an evaluation at the University Counseling Center where he was diagnosed with anxiety. Once again, a lot of the early signs in psychosis are misrepresented by anxiety or academic performance. So we definitely need to do a lot of psychoeducation in counseling to say, no, this is not related to school. This is something else. This is something more severe. No. The symptoms were intense but intermittent, which led to Brian to believe that his anxiety was tolerable and not a big deal. Brian began to pursue a graduate degree, but shortly after he started his first semester, his symptoms worsened. He had difficulties concentrating, once again, and could not organize his class schedule or his thoughts. As a result, he dropped a few classes and consequently dropped out of college. Brian reported delusions of persecution, claimed that he was being constantly followed and was receiving encoded messages through the bulletin board at his school. Once the psychosis is more, upfront, there is a lot of isolation. He spent time at home surfing the web in hopes of solving the encrypted messages he believed were being sent to him. He was hospitalized at the age of 23 as a result of terrifying vivid dreams Brian had, which involved secret agents performing a lobotomy and putting a chip into his brain. Brian was hospitalized 2 additional times over the course of 4 years, and now is being followed by outpatient facility community health center, where he receives individual and group psychotherapy. To make the story short, we have someone who has huge academic potential, a lot of socializations, the psychosis clipped his wings, difficulty concentrating, paying attention, socializing. So in this case, Brian was treated with an integrative approach, drilling and strategic, as I said, and the modality was using cognitive enhancement therapy. So I want to tell you a little bit of what's cognitive enhancement therapy. So CET, as the acronym stands for, is designed to provide an enriched cognitive experience through targeted and integrated neurocognitive and social cognitive training. CET works very well if you combine it or integrate it with, typical psychotherapy, medication, psychosocial education, and case management. CET has three components. Is you have to go through individual coaching, computer training, and a group. And something unique about CET is that they conceptualize your cognition in three particular themes. We call it cognitive styles. Well, we have the unmotivated style, the rigid style, and the disorganized style. So unmotivated style is very typical that if you say, hey, Paco, do you want to go here? He's like, yeah, whatever. No, I mean, they don't have any motivation. The rigid style, if we say, hey, Paco, do you want this? It's like, nope, I want it this way. And if you don't do it in his way, then there's a lot of anxiety. Or the disorganized style, that you say, hey, tell me about this, and we'll talk about X, Y, Z, 1, 2, 3, 4, 5, etc. By understanding this particular style, it's easier for CET to start developing strategies and interventions related to that particular cognitive style. In CET, we don't call them clinicians, we call them coach, and the coach is usually responsible to guide you in this journey. The best analogy is if you're the coach of a basketball of a basketball team, is the player, is the team, the ones who are facing all the struggles and have the capacity to solve what are the next play, what is the defense, who you're covering, and the coach is the one to say, hey guys, I'm putting you together, I'm cheering you, motivating you to do this, but at the end you're responsible for this, and here's the structure, right? Cognitive enhancement therapy is targeted, it's adaptive, involves repetition, it tries to do a lot of generalized and life situations, is engaging, is tailored to the patient's cognitive style, and is scalable. Usually the protocol is 45 individual sessions where they provide a clear and congruent ideas about the individual's plan, is supportive and facilitates instead of confronting, keeps the individual motivated and on task, and reinforce appropriate social behavior. We use the computerized cognitive training in this case. So they have used Sagacity again. They use the Sagacity, these three particular modules, to work on the bottom up, the reaction time, the one that I just did. We have the visual attention, and then we have the vigilance or sustained attention. And something unique about CET is that it's encouraged to do the computer training in pairs, not with the clinician alone, in pairs, because the peer socialization adds a lot of the social component and a lot of the motivation and the neurocognitive enhancement. So here's an example. This is the example of the visual attention and the vigilance. The groups are 45 groups. We recommend no more than 8 participants per group, and each group is 1.5 hours a week. And what do we do in these groups? We talk about the social cognition, and is designed to address this, key social cognitive deficit and start practicing with real examples and in every single session. So, for example, in the curriculum of CET, we always start with an initial recovery plan. We do a lot of psychoeducation in schizophrenia. We started thinking about to recognize signals of distress. What are the internal coping mechanisms? How do you protect? How do you create protective strategies for emotion dysregulation? How do you keep yourself motivated? And start, getting the gist. Now we're starting to touch neurocognition and what is important and strategies for memory. So, for example, it's one of the things that we do in CET. Schizophrenia is a brain disorder. It's not your fault. It's not because you didn't pray enough, or it's because you didn't eat healthy enough, or it's because of your mom or your dad or your grandpa. It carries a lot of guilt and a lot of stigma. We always emphasize the value of combining medication, psychotherapy, and avoid drugs. Right? It's very typical to say I just only need my my antipsychotic medication, which we know, as I said at the beginning of this, is really good for positive symptoms, but it doesn't touch the neurocognition. It doesn't help you to go to class and finish your academic degree. We recognize the signals of distress, and we separate in 5 or 4 columns: the emotional component, the thinking or the thought process, the behavioral, and the physical. It's very typical to say, hey, Pedro, do you sleep well? It's like, oh yeah, but I like to be all night awake. No, there's something going on there. It's not the insomnia. It's so your sleep hygiene is affecting your cognition, and we need to talk about that too. In terms of the social components, just we teach them how to do the emotional temperature taking, how to read the emotions, how to read the nonverbal social expression. In this case, is, oh, my dad seems in a bad mood, which is the emotional temperature taking. Social context appraisal. Not a good day to ask for a vacation, but I have to. But so how can I do it? So we rehearse that. Perspective taking. He must have a bad time, because we look at my boss is not particularly happy. So how can I approach this? Motivational account, how to explain ourselves, where we're coming from, which again, for some of these clients, they used to be very good at socializing, but now it's very hard for them. So we need to rehearse, we need to practice, we need to coach them, and just to change the things that are a little bit rusty, so they can have more fluidity socially. Elaborate speech. I have a good image here. Then we talk about adjustment to disability. It's very typical to say, but before this, I used to be in the prom committee. Now I can't. I used to do multitasking. Now I can only do one thing, and it's slowly. I used to have a lot of friends. Now I can barely talk to my brother. So we need to really talk about the adjustment to the disability in some cases, to really work with realistic expectations and to build from there. We cannot compare to other people. We always need to compare to our own selves, and then build them from there. This is, for example, this is a real conversation that happened to one of my clients, initiating and maintaining conversations. This is before CET. Hey, what's up, Peter? Not much. What's up? Not much either. Cool. Okay, bye. Right? And now, after combining the neurocognition, the social cognition, some of the coaching. Hey, Peter, how are you? I'm fine. Thanks for asking. Sam, how's the school? So you can see that the conversation is richer, and they will be able to initiate and maintain a conversation, which is very helpful if you want to keep a job, if you want to go to school, if you want to work in a particular profession. Also very important before CET. Hi, Arnold. How are you doing? Long time no see you. And it's very typical to hear, oh, good, Lara. I am schizophrenic now. So there's a lot of disclosure. There's a lot of lack of filters, lack of social awareness, the lack of social context that we talk about it. We coach, we train, and after CT, hi Arnold, how you're doing? Working as usual. Thank you for asking, Laura. How's your family? It's easy to navigate the social environments. We talk about the obstacles of implementing CET, which is something that we should be talking all the time. What are the obstacles of implementing CBT for psychosis, or psychodynamic, or using computers, etc. So finally, does it work? And it will be amazing to say that after 80 minutes or 70 minutes so far, to say no. But the reality is that it does work. If you look at meta-analysis, there's a famous one by Till Wykes at the School of London that compare all the different types of cognitive remediations. They work. They're pretty efficient, improving neurocognition, and some of them who have the social cognition to do that. If you look at another meta-analysis, you will see that there is improvements in managing emotions, in social perception, and emotion recognition, and theory of mind, which is the social cognitive approach. Usually, the effect size. This is now more research. They're decent. It's a good intervention, with exception that sometimes visual learning and memory are not, best. But overall, we have a lot of evidence that in terms of social cognition, they have a moderate large effect, that they can recognize facial affect. So that's important, because if I want to have a relationship and I don't know if my girlfriend or my boyfriend is telling me something, then my reaction is going to be off. Then are the effects last? And the answer is yes, they can last. We have studies that they track progress for 9 months, 18 months, all the way to 2 years. And the effects of improving neurocognition and social cognition last even after finishing treatment. And of course, after improves quality of life. Is CET effective in chronic schizophrenia as well as early course? Yes. Just look at this. The processing speed of CET improves overall versus EST. EST is enriched support therapy, just almost like treatment as usual. And look at the difference. We're talking about improving in neurocognition and social cognition, which is one of the, I will say, neglected areas in psychiatry or in psychosis that we're trying to address here. This is an effect. So after 3 years, you will see that CET is the one in the bottom, improve, and maintain the improvements. We also had a more fancy studies that look at the brain and the gray matter and the white matter, and we have seen changes at the structural level, which are the ones that are way more difficult to make. But if once the structure is changed, it lasts way longer. We also have an example of how important is the peer socialization in doing computer training, where we see that if you are with a peer, your reaction time and your attention improves more than if you're doing it alone. As I said, there's real life benefits of the functioning. We found that people that went from CET had 58% employment, so they went back to work, better social functioning, global adjustment, and activity to daily life. And in terms of the symptoms, negative symptoms, anxiety, depression, these interventions are not designed to improve the negative symptoms. Some of them experience better affect, but not necessarily a significant changes on that. No. If you want to do CET or other cognitive remediation, it's important to have a good baseline in verbal memory, which might be a very predictive for the benefits. Younger age maybe predicts social cognitive benefits as well. Early symptoms. If you want to go more into the brain structure, patients with low cortical reserve may also respond better to treatment, and brain's functional reserve may also be potentially a predictor of responses, meaning if your cognition is not as impaired, it's easier to repair that. So conclusions is CRT for everyone. It's a tricky one because given the heterogeneity of the illness, we have to be very, very aware of what's happening to our particular clients. As I said, I give you a spectrum of someone very chronically ill with a very, declined cognition. Were we able to improve? And the other one with more intact cognition to improve that. I will say, if you want to do this, just pay attention to the motivation. That is important, because lower motivation and the greater the chronicity are associated with poor outcomes. In conclusion, it's a comprehensive recovery-oriented approach to cognitive remediation, integrated bottom-up and top-down. One thing to know is the majority of cognitive remediation treatments are not designed for individuals who are in an inpatient unit or who are in a crisis constantly. The best way to implement cognitive remediation is if the individual has been integrated into the society and is a little bit more stable. Yes, you can have up and downs, but to be more integrated so they can have more benefits. You can individualize the treatment, and I think I need to stop so I can give you a couple of minutes of questions. Thank you so much.
Thank you so much. Yeah, we do. We have a couple questions already in the chat, but that was very comprehensive, so appreciate it. I think, Aaron, your question is a great one to start us off, really thinking about, so how can or should this be integrated in, CSC Navigate first episode type team? So first she's asking for CET sessions, how long are those usually? And is it intended for people who have not received any treatment or psychoeducation about schizophrenia?
No.
Yeah.
You can integrate CET at any point. It's intended for individuals who are integrated in the society. They're not in a crisis. They're a little bit more stable. So, for example, if you were discharged from an inpatient last Friday and you want to do CET on Monday, I will say no yet. You can start it, let's say, July 1st. Let's start it in August, mid-August of September, no? Once the crisis is done. CET sessions, the individual session can last for 30 to 45 minutes, depends on the stability. You will do the computer training in pairs, which is closely to 1 hour a week, and the group, which is 60 to 90 minutes on that. So if you aggregate all the CT treatment time, we're talking about between 2 hours and a half to 3 hours and a half.
Great, thank you. Yeah, Aaron, anything you want to add to that? I saw you come off video.
I think, well, first of all, thank you so much. That was super comprehensive and interesting. And then my other question is, it sounds like what you're saying is integration within another program could be possible.
Absolutely.
I guess one thing I would, as you know, I would be curious about is just
the only thing that I will say, and I'm talking about cognitive remediation in general, do not use computerized interventions as a standalone. That doesn't work. That doesn't work. It's going to be you against the wall, and usually the wall wins. You can integrate it with other components, but you still need the human component. And I'm looking at one of the questions here, that artificial intelligence will affect CT. I don't think so. Because if there is something that we know about this population, they have traumas with attachments. And they need the human component. They need the human attachment. And that is a fantastic thing to build, because that is part of socialization. No? So if you have social skills, or you have I don't know, cooking in your program, and you want to do cognitive remediation, absolutely. Because at one point, your problem-solving skills that you learn from cognitive remediation going to be applied to cooking, and cooking going to apply to to socialize, and then socialize can go to I want to have a date, and in the date I want to cook the pasta, and if the date doesn't want to do this, I can problem solve, right? So you can build the treatment, because remember, every single brain comes with a neck, and every single neck comes with a body. So if you talk about improving attention or memory, the entire body is going to follow, right?
thank you.
Absolutely. Any other questions?
One from our CHR program. So has this been used or could be useful for the clinical high risk group?
Yes. Yeah. Actually, I have a fantastic colleague, Michelle Freeman, who has tested cognitive remediation with clinical high risk, and the results are phenomenal. Phenomenal. They're able not only to keep their cognition, improving the cognition. They're able to recognize the early signs of distress, to regulate the emotions, and that is basically staying away from hospitals and more intrusive and intense psychotherapy. So yes, you can definitely apply it to clinical high risk, early course, chronic, and you need to be very careful. It is possible. You need to have more expertise how to integrate it in inpatient units.
If we have time, I have one more question. It really stood out to me at the beginning when you were saying, the first people who were doing this were actually, occupational therapists. And, a lot of our first episode teams, employment and education support is a big part of that. I'm sure this is very connected to, someone's employment and education. So how, it kind of a long errands question about integrating this with like a first episode team. Do you think this is primarily a clinician run thing? Like how would you integrate or collaborate with employment specialists?
No, I think the more the merrier, Elsie. So this started without psychology and psychiatrists and it worked very well. I mean, it went so well that the war lasted longer, unfortunately, right? But I think what the clinicians add is these techniques about creating the insight, the emotional regulation that OTs are not fully trained on it, or employment specialists. But I think if the clinician works on this and asks the employment specialist, hey, what do you see happening when they apply to a job? And they say, well, Pedro freaks out in the interview because of the eye contact. Then you go back, they collaborate and say, all right, I'm working on this, I'm working on that. And you provide the generalization of the skills that you're building here, there, and they're constantly, giving feedback to each other. No? And it's the same with OTs, and it's the same with peer specialists. We have seen, delivering CET and some components of cognitive remediation with peer specialists, and the results are amazing. Amazing. No? So remember, we're dealing with the brain. But also we're dealing with humans, and we need this human connection, and we need this experience, and we need to. I will say this is the challenge is to constantly evolve and be cognitive flexible and brainstorm and brainstorm and brainstorm. And with change comes a lot of emotions. But if you have someone that you trust and say, I want to be paranoid here, and I want to be very rigid. I want to be here. Are you here? Can you back me up? And the answer is yes. You will move forward. So that's why the collaboration is a key. It's key.
So really, yeah, the team-based part of coordinated care is another big strength to this. Absolutely. Yep. Well, we might have time for one more question if someone has one. I'll open the floor, but also just say thank you so much for all of this.
Absolutely. Thank you so much.
Yeah. So anything else folks want to say before we sign off?
The last thing I will say is don't be afraid of using cognitive remediation. Don't be afraid of using technology to treat cognition, social cognition. We're here. We help you. We're more than happy to help you to train you. We're more than happy to help you to teach you the ropes, how to integrate, old techniques with new techniques, with this complicated psychiatric illness. And the more that we can brainstorm and collaborate, I will say the better outcomes that we'll get for our population.
Thanks so much. Yeah, I think that's a great note to end it on. And thank you everybody for stopping in for today. So yeah, we'll send a survey and recording after the call.
All right.
But yeah, aside from that, have a great Friday, everyone. Yeah.
Thanks so much.